David can get them to you for more than $2,000.
I just went online last night.
Cutaneous and oral manifestations of HIV infection. I'm just curious who's here, and I know a few more will wander in, but I'll tell you who I am, and maybe you can tell me who you are. My name's Charles Steinberg. I'm a physician that's been doing AIDS care really since the early 80s, since it first showed up in Boulder, Colorado. And then I drove down and met people like David Cohen, who taught me what I needed to know to take care of those people. And did it until 2004, when I went off to Africa and have spent time there on and off since, living there for the first 3 or 4 years, taking lots of pictures. Going back periodically. I was there in September, and I'm going back Friday of this week, 2 days. So it's a... How many of you are second-year students, like I think this class is for? That clarifies a few things for me. How many of you are interested in dermatology? Great. How many of you are dermatologists? That'll change my talk completely. Great. I don't have to change anything. Because I have a sort of a generalist approach to dermatology rather than a dermatologist approach. How many of you are interested in Africa? Did I ask that already? Yeah. Okay, so that's the draw. Well, going back to Boulder, Colorado in 1985, here was Steve lying in bed. We're going to get some more lights down. Can we get them all off? I know you won't fall asleep. Molly and I rigged the chairs with wires, so if anybody dozes, they get reinforced. Can you see Steve a little better? What do you see? You see a guy lying in bed. 1985, that's what people with AIDS were, laying in bed in a hospital.
That's good.
That's even better. You can probably get a sense for his affect. He looks pretty depressed. He is covered with skin lesions. We're getting to see just the ones on his head and neck. And he's there to have them surgically removed, and there's no real treatment for what he has otherwise, HIV or dermatologically. And it's just a good way to introduce how important dermatologic conditions are for people living with HIV. Number one, extremely common. Many HIV patients will have this. Number two, it puts it right on the skin. So, somebody with HIV with high liver tests, unless they get to where they're jaundiced, you don't notice it. Somebody with a low CD4 count, you might not notice it at all. But somebody with a skin rash is going to be exposed to everyone. It's going to expose them to stigma. And so these people often have problems like depression and isolation and can need counseling and support. So right off the bat, we've got that to think about. And then from the dermatologist standpoint, if you're doing an exam, I want you to look everywhere. People will come into the clinic here or in Kampala, Uganda, where these pictures are going to be taken from, and say, I have a little skin rash, doctor, and they'll show you 1 square inch of skin. If you can't see what I'm doing over here, I'm showing 1 square inch of T-shirt. Anyhow, you want to say, somehow or another, I got to see most of your skin. Let's figure out how to do this. And that can be really hard where there aren't private rooms. Let me know if you don't hear me, by the way. I want you to be able to hear me. So looking everywhere, looking at mucosal surfaces, we're going to review real quickly what these primary lesions like macule and papule and others are. You want to look at how is this rash distributed over the body. That alone can give you the diagnosis. Where is it? Where isn't it? How has it spread from one place to another? And you want to see how that has happened over time. Did it start abruptly with a big breakout and now it's already going down? Did it start with a few things and now there's more and more of them and it's getting worse? The time course is really important. And then associated symptoms like itching and pain. The thing with HIV is stuff even as a dermatologist might be used to seeing commonly will all of a sudden appear uncommon. So just to make that point of everyone deserves a completely undressed exam, this woman who wasn't my patient had histoplasmosis, which she obviously covered from everybody in the waiting room. So I'll show you a more real-life example that happened in my practice as we go. So help me review the primary lesions. If I were showing you these little bumps you could feel up on the left side, what would you call them? All right, we are cheering for the Broncos. Sunday a week. and they're playing in New York in the Super Bowl. The little bumps up on the left, what would you call them? Papules, thank you. Little things you can palpate, I know that's not the same word, are papules, just easy to remember. And there's some spots up there that you couldn't feel. You could see, but you couldn't feel. Those are called, we're cheering, remember, that'd be loud. Macules. See, you guys all know this, you're just hesitating. We won't have as much fun if you hesitate, so jump in. If you're wrong, it'll even be more fun, because we'll figure out what you're thinking. How about on the right, the little things full of water? What do you want to call those? Bulla. I'd call the big ones bulla, and I don't know where I draw the line, but the little ones, you know, that we sometimes think of as little blisters are vesicles, because they're water-containing thing. Most of those, as I look at them, you are right, are bulla. So we've got a lady here with some purple macules and some purple large papules. And the word for large papules is nodules. So this purple spot right here that would be, you know, 1.5 centimeters or 2 centimeters, and you can really feel it, would be a nodule. And then we sometimes describe color, like the erythema. But the key word here is these are primary lesions. And primary doesn't mean, oh, primary in my thinking. It means they're what show up. They're the first things on the skin. Then later on, after scratching, after putting on creams, after going swimming in the ocean, whatever, you might see secondary changes. And just to look at a couple of secondary changes real quickly, the top right one, I don't know if you'd have a word for that or not. What would you call that? Real loud, real loud. Keratinization. Keratinization, over-keratinization. Actually, right? It doesn't look like the skin nearby. And so you could call it scale formation, plaque formation, hyperkeratinization, thickening of the skin. Why do I care what you call all these things? Anybody got a good answer for that?
Describe them in something.
Yeah. I mean, in this day of modern, take a picture with your iPhone, a picture can be worth 1,000 words, but you may be calling the resident when you're an intern, or you may be calling the dermatologist when you're a doctor in Africa, which is what I was doing by email, and trying to describe things and throw in a couple pictures. So you really want to have their vocabulary down. There are a couple of secondary changes on this picture. Make it easier. What are the two that jump out at you? You can just describe it if you don't know its name. So there's areas that are white things. Thank you. That is beautiful. I'm talking to my dermatologist. I say, you know, there's some little areas that are white things. He knows what I mean. He means hypopigmented. If he's nice, he might even educate me and say, yeah, those are hypopigmented areas that result as a secondary change after inflammation. And he might even go on to say some areas will be hyperpigmented in African people. So hypo and hyperpigmentation, which you can see a teeny bit of. And then there's those other thick lumps. What are those? Scars. Is that over here? Scars. Thank you. What about them? They look like regular scars? Yeah, they're overgrown. They're thicker. They're heavier. What do we call hypertrophic scars? That's what we call them. Is another name? Keloids. Okay. Somebody on this side, what do you see here?
Punctate lesion.
Yeah, a punctate lesion. You know what created it was he scratched off a papule. So the secondary change is really, if you look at it, an excoriation. Okay, so that was just the warm-up for participation. I would love your participation as we go. In fact, my whole presentation will die if you don't participate. And you want me to leave happy that I was here, right? Right? Yes. So let's go with a case and see what we see. This patient's been sick for a week with rash, fever, sore throat, swollen glands, and when you look at him, you see this non-distinct rash. Somebody might say, oh, they're just a bunch of macules all over the place, maybe a few papules. And then you'd see this thing, which illustrates our first point about always look at the oral mucosa, because we see something. What do you see? And again, you can just describe it or tell me what it is or whatever. You see Candida. What part's the Candida? These aren't trick questions. Yeah, the whitish stuff. is actually hypha and spores of the Candida yeast growing. If you scrape it off and look at it under a wet prep like you learn in gynecology to do for vaginal discharges, you'll see exactly the same thing. And I guess it was a trick question because the red is also Candida. It's the inflammation without the forming of the exudate usually. And in fact, there's three kinds of Candida, red, white, and just sort of tan, where it's atrophic or not doing much at all. But that's Candida. So now what do we got? We got somebody sick for a couple of weeks, sore throat, swollen glands, Candida, and you went as far as to get an HIV test and it was negative. So what do you say?
Good. Good. Said the HIV was negative, and I said that's good.
You know, I have 66-year-old years, so I heard if the HIV was negative, I'd ask.
No, I just blurted out the word good.
Good,
The
it's
HIV
good.
was negative.
So now that I've got this person's HIV test, I can confidently go have sex with them. Right? Without protection, of course. Wrong. This person has got primary HIV infection. Win silver dollar prize over there. So this person's just coming down with HIV. They got exposed 3, 4, 5, 6 weeks ago. It's too early for their body to have made an antibody test, so the test is negative. But if we do an antigen test, either P24 antigen, or currently we'd look for the virus itself with this polymerase chain reaction RNA for the virus, it would be floridly positive. It's sky high. It's actually the highest it's ever going to be likely in this patient. So patients, when they're acutely infected, half of the time they get sick, half of the time they don't. If they do get sick, they often have a rash, which is why it gets this 5 minutes of this talk. And the interesting thing to know is they're the most contagious ever because they're just spewing with millions and millions of viral particles per cc instead of oftentimes it's tens or hundreds of thousands. So this is something to watch out for. It's called acute HIV infection or seroconversion illness or acute retroviral infection. All sorts of names for the same thing. And so the bottom line, you know, you like to say, well, what is this going to do me good next year in a clinic or someplace, is if you see someone that looks like they have mono, you know, sore throat, swollen glands, sick, rash, all that sort of stuff, and you could see thrush with mono, by the way, or Candida with mono, but particularly if you saw something like this, it's a great time to say, have you had any possible exposures in the last 6, 8, 10, 12 weeks? Because you may be diagnosing primary HIV infection, and there's more and more excitement about treating this as early as possible before the immune system has been affected in more permanent ways. And that's debatable. But anyhow, it's worth thinking about. So what are the typical skin manifestations of people with HIV? I made you a list. I think it's got 6 or 7 or 8 things on it, so I could have fun showing you pictures and we could have some organization to our thinking. Scaly rashes, you can read the rest. Itchy bumps, non-itchy bumps, purple bumps, and then blisters, erosions, crusts, and then we'll get a look in the mouth. And if we have time before 1 o'clock, we will look in the pigmentary changes in the nails and the hair. And I did spend a lot of time in the parks of Africa, so I like to illustrate the scaly rashes with a scaly animal, the crocodile. You only get this close when you're in a big boat. But here's a scaly rash. And it's scaling around this patient's nose, and if you look further, there's a little redness, and it's around their ears and maybe around the back of their scalp and their forehead. Does anybody have anything you want to say about this? An idea, a thought, a description? It's pretty much just in those kinds of areas, but no, it's up around his ears and the nasal folds, those kind of areas. Good question. Because if it was on his arms and legs, it might be thinking of something completely different. Are you being quiet because you're reticent, but you have an idea? If you just have an idea and you don't want to say it, raise your hand. Then I'll ask you to say it. Okay. When you study dermatology, you'll study, well, what's in the skin? And from your own life, what's in the skin right here? What do you end up doing here? What do you wipe away here? Oil. This is the highest concentration of oil glands, sebum glands, in the skin here and in the scalp and around the scalp margins. So sebum glands, when they get inflamed, produce a situation called seborrheic dermatitis. Here's another example where it's more in front of the ears and around the scalp, and those are the words if you wanted to know them. And what this is probably an infection of that oil with some little fungus. It has a name. We should say the name. It's somewhere in the list. Pityriasporum. Is that right, David?
Yes.
Yeah.
May play a role, not for sure.
May play a role, not for sure. David is our infectious disease consult today. So antifungal creams can help, like ketoconazole creams, and anti-inflammatory creams like hydrocortisone can help. Because either way, you're lessening the inflammatory reaction to this possible infection in the skin oil. Very common. And seborrheic dermatitis is common anyhow. So you may have a patient say to you, you know, I used to get a little flakiness here and it went away, but now it's really bad, and that might be a period of time where they developed HIV infection. So it changed from something that was common to maybe different or uncommon. Okay, another crocodile-like scaly problem. And we want to go a little bit faster so you have more fun. Who wants to describe this? I will turn off my iPhone. No, it's not. My son fixed it. Who wants to describe this?
I'll describe it.
And just real loud again.
Somebody over
See
I'll
what I mean?
describe it.
Sir.
It's a discrete oval lesion with a scaly border and somewhat of central clearing.
Beautiful. That's everything. Did everybody hear that? It's circular or oval. It's pretty discrete. We don't see anything outside of it except for maybe some little spots. Scaly, and maybe there's more on the edges and less in the center. In fact, maybe there's so much more on the edges and less in the center that sometimes it could look like a what?
Ringworm.
A ringworm. So this is classical fungal skin infection, or ringworm. And sometimes you'll see it looking this good, sometimes it won't be quite oval or quite as perfect, but you'll get a sense of it from, you know, the person scratching at it a little bit. It develops as a series of rings, and this photograph really illustrates that, where the advancing border of the inflammation from the fungal infection keeps getting bigger and bigger, and behind it is a little central area of healing. So these infections are called tinea. Tinea corporis when it's on the body, tinea beardae when it's on the beard. It's pretty easy, and tinea capitis when it's on the head. All these little girls don't have HIV infection. This is just the greeting committee at an orphanage that my wife and I visited. But you can see almost every one of them has, because it's so easily spread, a tinea infection of the scalp, tinea capitis. Okay, are we going so far so good? Anybody eating lunch? Next one's a little ucky. What they say in Uganda is they say, are we all together? And that's what I said, are we going so far so good? So it lets me know you're following me, or I should go slower, or I should go faster, or I've lost you. Are we all together?
Yes.
Yeah, okay. Stop me if you have any questions, please. I'm not in a hurry to finish as much as to be here for what you want to know about. So if fungus grows around the toenails, it is particularly stubborn. Either tinea unguum or this fancy name, where is it? Onychomycosis. So mycosis is fungal infection, and onycho is of the nail. And they get thickened, they start to crumble off, they don't grow normally. The skin isn't as much involved as the nail. It's usually bilateral. It tends to have a tendency, people tend to have a tendency towards this. So it's hard to get rid of, and oftentimes takes systemic antifungal drugs, which in this country at top-notch prices you can get antifungal drugs for toenail fungus. There's one more thing I want to say about this one. Otherwise, in the resource-limited settings, they use a drug called griseofulvin, which is a good antifungal drug, but pretty toxic, and one that I mostly stay away from because this often comes back even after it's cleared and treated, and so you wonder where you're getting to. So I had one more unusual fungal infection to challenge you with. Now that you've gotten through AIDS Derm 101, we can get up to 401. What do you see here, other than an unhappy man? You can just describe it. You're calling me on your Skype now. You're in Timbuktu and Skyping. Probably not Timbuktu. You're in Addis Ababa. Somebody want to take a guess? So there's lots of signs of inflammation. Is that what you said?
Yeah.
And you can tell that by all the redness. Absolutely. What else do you see? You see redness. You see...
Some excoriation maybe?
Yeah, you know, those are actually splits or cracks. You know how when your lips get really chapped, they'll split? This gets so bad it splits, and it's actually quite painful. So you see some painfulness, some redness, and you see the whitish stuff, which is what's confusing you.
He's uncircumcised.
And he's uncircumcised, we say. So, if this were a woman and you saw reddishness and whitishness, would you have a clue what was going on in her genital area? Woman says, I've had itching and pain for the last 3 weeks, and now I have this whitish discharge like cottage cheese, and my... say? A yeast infection. So women get vaginal yeast infections all the time. Men with AIDS get this similar area, uncircumcised penis and a warm, moist area under the foreskin and over the head of the penis. Candida or yeast infection. And this whitish stuff, if you scraped it off and looked at it under the microscope, would be the same as a woman's yeast infection that you do all the time. So just unusual, and it tends to cause those splits and cracks, which is eventually what gets the guy in because it hurts so much. Okay, so just to talk about fungal skin infections, I think we've said all of that except to say the last line, which we will see some examples of fungal infections that are a manifestation on the skin of a more deep systemic infection. And in terms of treating in resource-limited setting, we first think about just improving the local environment. So that last poor individual, we know a yeast infection grows where it's warm and moist, so we want him to somehow, through cool baths or whatever, cool and then drying to keep it less warm and moist. Athlete's foot is the best example, where if you can keep the space between your toes cool and dry, the athlete's foot will go away. Local treatment before you go on, like clotrimazole cream, which really has very little in the way of problems. And then, whoops, come back. Griseofulvin, maybe they don't come back. That's the other thing you get to do in Africa. Oh, you can't see my desktop. Never mind. I have some lions on the desktop. Griseofulvin for extensive disease, and or the nails, and when you're following for side effects. And then here we use a lot of fluconazole, but in resource-limited settings, it's ketoconazole and less so itraconazole. Ketoconazole has some drug-drug interactions that are really important, so we have to pay a lot of attention when we use that. And then looking under the microscope. Okay, let's go away from fungal infections to something next. You don't need to know what this is, but somebody's now going to tell me what they see, because you've all gotten good at just describing what you see. Maybe somebody who hasn't talked yet, and maybe somebody who talks real loud, so I'll know where to look. Where is it?
Chest and shoulders.
Yeah, pretty on the back, around the neck, and it actually looks like, if you could see outside the picture like I can, like it's coming up from the axilla and spreading up that way. The top of the shoulders might be spared. So it's on the flexural surfaces, the inside of the neck, the armpit, the places where the skin is the most thin. Other than that, you might not have a whole lot to say. You might say there's some papules, there's some depigmentation, or hyperpigmentation rather. So that leads you to know it's chronic, that hyperpigmentation, because they've probably been scratching at it for years and led to increased pigmentation. Here it is in some other flexural surfaces, the antecubital fossa and the popliteal fossa, mostly just seeing hyperpigmentation and inflammation. And that's what I want you to be able to say. I don't care if you know what that is, but if you can say that much to your consultant, whether it's your resident or your dermatologist or me, we'll be able to help you figure out what it is. And it's atopic eczema. This is exactly what, when people have a skin allergy, it will look like. It's chronic, little bumps, pretty non-distinct, but in the flexural areas. So when you're in your peds clinic and you have the babies that you see, and some of them are rashy right here and right here, you can just sort of imagine they have eczema and look some of these other places. Okay? Atopic and contact eczema are a couple of the illnesses that get worse with pre-existing conditions. And so, get worse as pre-existing conditions with HIV. Sometimes the sentences flip around. Here I want to show you something that's really interesting. In Africa, we put a woman on antiretrovirals for 3 months, and she was on a drug called Triimmune, which has 3-TC and D4T in it, 2 of our nucleoside analog drugs, one of them good and one of them not so good. And it's got a non-nuke called nevirapine. And nevirapine is very potent in causing rashes. So we're always looking at 2 and 3 months to see if this woman has a rash. And lo and behold, she walks in and she has a rash. The interesting thing was to turn and look at the other side. This is really just a rash of the flexural surfaces. And in taking a history from her, sure enough, childhood, she had a history of rashes here and here. And we have just sort of created more of her atopic dermatitis by strengthening her immune system a little bit with our ARV drugs. We've strengthened the body's reaction to whatever she's allergic to, and now she has a whomping atopic dermatitis. But it's not the nevirapine rash. And we actually decided not to stop the drug that usually causes the rash in people who usually take it, but to just treat her with cortisone cream, and she got all better. This is a funny thing, and we'll see it in other HIV talks. Sometimes when the immune system's weak and you make it stronger, problems flare up rather than go away if they're problems that are based on the immune system's strength and activity. So even infections that you think were gone will flare up when you get an improvement in the immune system, but that's a different opportunity. What other skin dermatoses? So we need another animal. I want you to think thick-skinned elephant skin, and look at these couple pictures, and just see if you can talk to me about what these lesions are. You don't have to know what this is. We're learning more about how to talk about them than what everyone is. Where are they? Are they on the neck and the antecubital fossa and the popliteal fossa? Back of the hand, back of the knee, back of the shin, and back of the back. Those would be the opposite surfaces, the dorsal surfaces or the thicker skin surfaces. And we see sort of roundish, scaly plaques. That one might, even if it had central clearing, the big one, you'd think, oh, is that ringworm or something like that? But there's a bunch of them. Anybody want to say any more? I don't want to lead you. If you could get close, you'd see that the nails were pitted. I have looked in on this picture, and the nails, sure enough, are pitted. And these are examples of psoriasis. And you probably know somebody with psoriasis, the heartbreak of psoriasis, the thick plaques that are scaly, and they do respond to treatment. But with people with HIV infection, they get much worse. So this gentleman never had psoriasis in his awareness. He got HIV, he got psoriasis. We treated his HIV, and his psoriasis went away. So it's just a sign of that immune system being out of balance that this condition emerged. And it can look different. They can be less plaquey and more just spots. Here's an example of the nails. So, psoriasis. Made worse by HIV. Sometimes it's what shows up with HIV and responds to treating the HIV as well as to other treatments you might use. Okay, let me show you another, probably most common rash you ever see. And this could be in any country. Anybody want to give me a few words? Just tell me what you see. Your lunch really tastes better when you participate. So there's macules and there's papules. How many of you are medical students 1, 2, 3, or 4? A few of you. Okay, I was trying to see if we could get credit for the different colleges and your college competition for shouting out, even if you're not right. So Lynn says macules and papules, and that's right. And then what really draws me about this rash is absolutely nothing. There's just nothing distinctive about this rash. Let me show you another one. Macules and papules, and just nothing much distinctive. Sometimes it's on one surface, sometimes it's on another. And here your history would be key, because the patient would start telling you, here's a third rash. Let's see if I can get there. Yeah. That, gee, just 2 weeks ago I started a medicine. Just 5 days ago I started my amoxicillin. Just 10 days ago I started nevirapine, which is that ARV drug I said causes rashes. These are drug sensitivity rashes, and they're often just like no big deal rashes, just little lumps and bumps, little itchiness, none of that hyperpigmentation from a chronic thing, usually nothing much that's going to draw your attention, and that's what should draw your attention. And this one actually is a little boy in the pediatric clinic who had been taking nevirapine. Sometimes it's a whole hypersensitivity reaction and the person is sick, all of the skin is inflamed, the face can be swollen, and you can see things, general systemic toxicity like fever and lymphadenopathy, hepatitis, and eosinophilia. The drugs that are involved, these are the categories of ARVs if I'm jumping ahead, and the non-nucleoside reverse transcriptase inhibitors across the board tend to cause rashes, but particularly nevirapine causes the most serious one. All the anti-TB drugs cause rashes, which is one of the problems with treating TB and HIV at the same time, starting the same day and 10 days later having a rash is hard to know what you've done. A commonly used drug, cotrimoxazole, we call it Bactrim or Septrin, causes rashes. Although interestingly, here when we use it to prevent pneumocystis, my experience was a third of my patients might have some sensitivity reaction to it. In Africa, it's about 2 or 3%, so it's much less common. And then abacavir, which is another nucleoside analog drug, an ARV that has an unusual hypersensitivity reaction. The red asterisks mean just to note it in your head, and if you ever get to use it, learn about it because it's potentially life-threatening. Okay, we've gone through the scaly rashes. The rest of them go faster, and I'd love your participation with the itchy bumps, so I'll show you one of my favorite pictures. I actually sat next to this guy. I was in the car, and she was out of the car. So here's an itchy rash. This woman's got bumps on her arms and legs. There I go describing it for you. You might notice some of them have already scarred, and they're sort of whitish scars. Some of them are hyperpigmented. Use your psychic pointer, and I'll point out those ones that are hyperpigmented. Some of them are still papules. They're on the arms, and they're on the legs. This had a lot of names for a while. It was different folliculitises and prurigos and all sorts of names till they figured out what it was. Here's that picture we saw early on with the excoriation. So one of these papules has been scratched off. And then in about 2003, a group came to the clinic I was working in, actually, and figured this out and called it pruritic papular eruption. And one of the fun things to learn is how to spell pruritic or pruritus, which isn't an inflammation and doesn't have a double R, but has an R, a U, and an R. So they biopsied 100 patients. They did immune studies on these patients and discovered as immunity dropped, people were getting hypersensitivity reactions to mosquito bites. And this is a brand new idea. So, you know, the AIDS consultant from the U.S. coming to Africa, seeing all these, had no idea what was going on. And then we learned in Africa, with some help from, in fact, this is the dermatologist at the top, Jack Resnick, that I stayed in touch with via email afterwards and would send him pictures of rashes and describe them, and he'd help me out really for years. It was a great, this was in JAMA in 2004. So PPE, or papular pruritic eruption, for years we didn't know what it was caused by. Now we know it's a hypersensitivity to bites, and it reflects the weakness of the immune system. So a lower CD4 count over more time, you'll tend to see this, and it's in the areas where you get bit by mosquitoes, you know, because you have short sleeves and shorter skirts and pants. So it's helped by things as simple as bed nets, mosquito nets at night, to prevent mosquito bites. Otherwise, you treat it with antihistamines or Caladryl lotions or steroid ointments, something to just lessen the itching, and try and get the person on antiretrovirals, another phrase for that being HART. Some places we've tried to correlate it with failing antiretroviral regimens, that this problem would flare up and come back. And it certainly happens anecdotally, but it's hard to use it as a guide. Okay, here's another itchy bump. I want your help on this one. How would you describe this? There's more sitting over there, so I looked there first, but I'm counting on you guys. You've had more than your share of answers from your side. Where is it?
It's in the umbilical region.
Periumbilical. and it's itchy bumps, but what do you see?
I mean, they're scabbed over.
And why are they scabbed over? Because he scratched them all off. So this is another way to see excoriations, is you'll see scabs. Does anybody want to tell me what it is so far? For the $10,000 prize. Huh? Scabies. He said I just had to throw in a prize. So this is, I'll show you some more examples of scabies in the interdigital webs. Little itchy bumps. As bad as it is on this person's hands, almost everywhere. It can even get worse. So you can see on the hands and the feet of this one, and Sarcoptes scabii is the name of the bug, and also along the wrists. So really common places. This is one of those rashes that when you hear where it is, like in the first sentence, you take a half a step back and you don't shake hands. I'm all for shaking hands with patients. I'll even hug a patient if that's appropriate, but not when they have scabies, because this is really contagious. And what's being contaged is this little guy. Have any of you ever seen a case of scabies? 1 hand, 2 hands, 3 hands, 4, 5 hands. You see these little bumps, and then if you put a drop of ink on them, you'll actually see a little tunnel go away from the bump under the skin sometime. And what's happening is this guy's going along, this gal actually, laying her eggs, burrowing under the skin, laying eggs. So you see the burrow track, and then the bump is the allergic reaction to the foreign protein of the scabies egg. It's an allergic reaction to the egg. It takes a few days to develop. And the reason it's great to know that is once you give the patient a diagnosis and you give them a treatment, you send them home, you want to be sure and tell them, oh, by the way, you may get a few more bumps for a few days after you've put on the treatment, because those eggs had already gotten laid and they're going to cause a bump whatever we do. So otherwise, people put on the treatment and the next day they notice 2 bumps and they call you back and say the treatment's not working. So you need to tell them what the likely time course will be. I think you've been reading behind my back. The Norwegian scabies, crusted scabies, can just get awful and totally encrust the skin. Okay. So while we're with itchy skin, we can just talk about dry skin. This is the most common HIV-related skin trouble you see. Somebody comes in and they're itching, and you look and there's not much, or there's a little lichenification or hyperpigmentation or something, but nothing really as a primary lesion. And when you look more closely, many areas there's dry skin. And it turns out that rash is at the places they can reach to scratch it. So it's not as much here where you can't reach, and it's more behind your calf where you can reach and scratch it. Oh, we got pruritus spelled right here too, so P-R-U-R. And the main thing that dries our skin out is soap. Soap takes the oils off the skin and lets the water evaporate from the skin. So in this relative humidity of whatever it is, minus 10%, I mean, we have no humidity. All the water is leaving our skin, and that's why women with soft skin are putting all these creams and oils and emollients on their skin, is just to keep the water in. I used to, when I trained here in pediatrics, they told us to have the kids get moisture on their skin with this and then just cover them with Crisco, which is a cooking lard-like oil, but just something to keep the water in the skin. So saran wrap would work. Anything that you could put on the skin to hold the water in. But avoiding soap, which is taking the oils off, and using lots of things to keep the water in. Okay, non-itchy papules and nodules. And some of these might itch a little bit. This one I wouldn't scratch. So the last one was a leopard, so that makes this the cheetah. Okay. So this patient says, I don't mean to have the arrow there, but now I see where the arrow is. I've had these bumps for the last year. They keep getting worse. You call me, you're going to describe papules and maybe even some nodules on the dorsum of the feet and maybe other places. And there seems to be a line of them up the leg. We'll see if we see that. Any ideas? You don't have to know what this is. One of the things that's really common is the viral infection that causes verruca, HPV, going wild in HIV-infected people. So these are just regular old warts. but more than your usual number, and spread. And they can be spread by contact, so probably as this person is, whatever they're doing, pulling on their socks, if they're shaving that low, or if they're scraping them off or whatever, just spreading them. This is a particular kind of wart that I saw frequently. The fancy word for wart is verruca. That last one was verruca vulgaris, which doesn't mean vulgar, but just means a common wart, verruca. And then this is verruca plana, or flat warts. But what's bizarre about this distribution? Anybody want to take a guess? You see a couple things.
There are lines that almost look like scratches.
Yeah, there's 3 or 4 lines. The most obvious one is here above her sternocleidomastoid muscle. There's one on her chin, and there's a dozen little ones there. Those are all little warts. And they're spreading along lines. Why? They're not the usual skin lines that we learn when we learn dermatomes. They're helter-skelter all over the place. So they're not part of the skin. They're lines of trauma. If you know these answers, then you're sitting there thinking, speed up. And if you don't know these answers, you're fascinated. But if you know these answers, yell out. So this is a place where she scratched the wart and spread it so clearly along the lines. A dermatologist named Kepner described this. And it's called Kepner's phenomenon. So that's what's happening on her forehead as well, and it's just a more unusual practice of her neighborhood of shaving the forehead. Women who sort of want to raise their scalp line as a sign of attractiveness. She was raising the verruca plana and spreading it all the way up her forehead. And for men who have warts in their beard or anywhere like that, it gets to be a real problem figuring out what to do if they're shaving. Okay, there are verruca of the genitals. They sometimes get called Condyloma Acuminata, and they can go from bad to worse. So again, I'm going to show you some of the worst ones I saw, just so you can see what happens with HIV infection and no care. This poor woman was pregnant as well, and so she needed these surgically removed to just prepare her for childbirth, to get rid of the mass. And this wasn't her partner, but this guy had equally neglected scrotal warts, and they can appear anywhere. These are all pictures I took, but I was looking at a textbook and I saw one right in the urethral meatus, certainly anywhere inside the female genital tract. You name it, anywhere in the genitals they can appear, even on the skin nearby. So we mentioned HPV. It definitely gets worse with HIV infection and can get a little better when you treat HIV, but warts are stubborn. Warts are very stubborn, and they're hard to get rid of. And basically our treatment is almost all, in the developing world anyhow, killing the skin that the wart's living in and hope you get much of the wart too. So surgery works, cautery works, those slowly dissolving solutions, podophyllin and salicylic acid work, all by killing the skin. There's one treatment at the bottom of the next slide called Aldera. And Aldera is a much more expensive cream that seems to call the immune system to the wart and get rid of it that way. So Mark Twain's ideas of bringing magic to treating the wart, or spinning a cat around your head 3 times at night in a cemetery, it may be what's calling the immune system. And other things, like in pediatrics, we used to have this bright red tape that had poison written on it all over, and then we'd cut a little piece and put it over the wart, and the occlusion plus the suggestion worked as well as anything else. What did I forget to say? Oh, just that these warts are, not these warts, but this virus and different strains of this virus than the usual wart-causing strains are oncogenic and can lead to cancer both in men and women. So the cervical cancer and the pap smear whole understanding has been radically changed by going after who has HPV infection, and the same with anal carcinoma in both men and women. Okay. Here's something that looks like a wart except for one thing. So you're calling and saying, Charles, this lady's got something like a wart under her eye, but there's one thing different. What do you see? Say?
Is the crust in the middle?
Yeah, it's depressed in the middle. It's scraped out in the middle a little bit. Going back to our scabies picture, it's umbilicated. It has an umbilicus, sort of. It has a belly button looking appearance. And this is what's called Molluscum Contagiosum. It's a different virus than the wart virus. It's maybe even a little more contagious, but it's a little bit easier to get rid of. It gets terrible with people who are immune suppressed. So this was actually my friend Steve from those first pictures. He was just literally covered with these lesions everywhere. In each one of them, if you look closely, like my pointer, this one, you see the central umbilication, that little white spot. And they can be fewer in number, but again, with clear central umbilications, this one has it very clearly.
Do they only occur on the face?
No, they can occur anywhere. They're spread by contact. So, you touch yourself here, you touch yourself there. I forget what the studies are, how many times we touch our face in a day, 40 or 50. I mean, we all do it all the time. So it's a huge way we spread things around. And it's particularly a problem in pediatric clinics where the little kids not only touch their faces, but touch everybody else's faces, stick their fingers in everybody else's eyes, then touch their own eyes. So no, Steve had it in the beard area, which I guess would still be on the face, but he had it on his extremities, he had it in his genitals, and these weren't genital warts, these are all sort of malignant molluscum contagiosum, not malignant like they're cancerous, but malignant just like they're all over the place and bad. And he has some scars from ones recently removed and more remotely removed. And quite honestly, I was seeing Stevie didn't have any money in my office and just curetting these off one at a time. And it doesn't hurt that much, and he was just letting me do it. But when it got this bad, we got a general surgeon to agree to put him out for an hour and just get him rid of most all of his lesions. And on the legs, like you asked about.
Question?
Yeah.
Is there any HPV vaccination? Is that you do encounter that in your blood?
Well, so the question is, you all know about HPV vaccine to prevent, to be vaccinated with 3 or 4 of the most oncogenic strains of HPV to prevent cervical cancer and ultimately anal cancer that I don't believe prevent warts. And I don't think that was available when I was there, no. And, I mean, getting medical students to get hepatitis B vaccine was a rallying cry. I remember we were working for that, so that sort of tells you the cutting edge and how...
There's studies being done to look at its efficacy in HIV infected patients.
With the vaccine?
Yeah, with HPV.
So, yes, it's being used in studies with people with HIV.
Is that given as adults?
Is it given in kids yet, like it is here? No. This is given in HIV infected women to look at immunogenicity and see effect on certain cancer. Maybe too late, but I don't think it's being given to kids at all. Maybe probably in South Africa, but I don't even know about that.
The Gates Foundation has some programs to try and make it cheaper, but it's still really expensive, like $5 a vaccine or a series of 4 hits. Not possible for most cases.
So here's one more patient, just because whenever you learn something, you want to learn the exception to something. This patient has these umbilicated papules just like molluscum all over, but they've appeared in the last 12 days. And not only that, but he's been getting sicker and sicker, and he can barely walk, and he's febrile, and he feels terrible, and he can't eat, and he has a stiff neck. So when he has a spinal tap, they discover he has cryptococcus growing in his spinal fluid and has cryptococcal meningitis, which is one of the common ways people present in Africa with AIDS, and sometimes shows skin lesions that look pretty identical. So that can happen here. Purple-brown lesions are easy because they're Kaposi's sarcoma. And this is a tumor of the little vessels, and it is god-awful looking, particularly on the face, but it occurs anywhere. I'm going to tell you a couple things about it. One is that it tends to plug up the lymphatic flow, so you'll see swelling around it. When I saw this woman walking in across the waiting room, I thought she's been battered. It looked like she had a black eye and a swollen face. And I got closer and read the chart. She had Kaposi's sarcoma. It can occur commonly in the oral cavity, so this is another reason you always look in the mouth, and all the way down. This is a biopsy from, a picture from a colon specimen. Here's a patient I saw who had it on the bottom of their foot, and I just thought it was stunning how, first of all, it's sort of a gooey lesion, which is unlike KS, but we biopsied and it was, and then how stunning it is, you can just see the lymphatic spread. that line of darkness going up the foot, really making it clear. And when that lymphatic spread takes over the whole leg, you get this tree trunk-like or woody edema. It feels like wood. You don't have anything to scale, but this is like 3 times the size of his other leg because of Kaposi sarcoma up in the inguinal lymph nodes and the top of the leg. And only because we're running short on time, I'll tell this story fast, but everybody thinks Kaposi's sarcoma was named after Dr. Kaposi. It was actually named after the town he was from. He was named Dr. Cohen in honor of David Cohen. And the way I heard the story anyhow is he was in love with the head of dermatology's daughter. And they were Catholic and he was Jewish, so he changed his name from Cohen to the village he was from, Kaposi, and went on to marry the daughter and become the head of the department and get this named after him. So you can't always guess the name is from the person. So the one thing that can look like KS and isn't, almost the same story. Thank you. Almost the same story of purple bumps, except again like the cryptococcal patient. This has come on over a few weeks. 3-week history, fever, liver and spleen enlargement. The patient feels overall sick. And this is a simple bacterial infection. This is sort of like cat scratch fever, but in an immunocompromised patient. And it's easily treated with our common azithromycin. So patients that we thought might have KS, you do a quick biopsy, special stain, find these interesting bugs, treat it, and it goes away, and you've made a major change in that person's life. I think we're going to get as far as blisters, erosions, and crusts. And I didn't have a great picture. I looked through them last night, and I figured, well, after a while, these 2 cob fighting over the woman back there should have plenty of blisters, erosions, and crusts. Pains down my arm and blisters over the last 3 days, all the way down my arm, Doc. What's the distribution? You all know that. It's dermatomal. It's following the path of a nerve distribution. And if we wanted to be sure about that, we'd say, oh, I remember this distribution. I'm trying to remember it now. It's C5, 6 or something like that. Let's look on the shoulder and see if there. And sure enough, you look at this guy's back of his shoulder, and he had a couple of these little lesions, and then many of them all the way down the arm. So here's another somewhat dermatomal distribution. Although if you were really honest, you'd say, well, I can't do that looking backwards. This is a different dermatome than this. This is probably several dermatomes. Anybody know what's causing this? It's called shingles, I heard that. Or herpes zoster, and it's caused by the chickenpox virus getting reactivated and causing herpes zoster. This is a somewhat common infection in adolescents, in elderly people, time when the immune system is challenged, and then in people with HIV and other immune-compromising situations. It doesn't mean the patient has HIV, but interestingly, 1/3 of the patients in Uganda who have HIV present with this. So it started to look like if I saw this, I ought to really be sure that person got screened for HIV. The lowering of the immune system simply lets this escape. It can be the first manifestation, multiple dermatomes, treatable with acyclovir in high doses, particularly if you treat early. And the book says a week, or another book says 2 weeks, but I would treat until all the lesions are crusted up. Usually it doesn't disseminate, but this woman had an original dermatomal distribution on the left side of her spine. And you can see by the insert picture, later she got sick and it spread all over. And this is where that picture of secondary changes comes from, because this, if you look at it now, the hypopigmentation and the keloid are all in that dermatome. And this is where a gentleman had a herpes zoster outbreak and now comes in to say, what can you do about my keloid and my white spots? And there's absolutely nothing we can do about them. If it involves the nerves going to the face, T1 and T2 distribution, you can see involvement of the forehead and the eye, or of the cheek and the nose, and you can see how it stops pretty much at the midline. I haven't emphasized that. Herpes zoster won't usually cross much the midline because it's following the distribution of the nerve in that dermatome where the chickenpox virus was resting in the dorsal ganglia. So I said that at the end, but you got the picture, I hope. And here's what it looks like when it's destroying an eye and doing something awful. So are we together still with herpes zoster? Any questions? A couple more blisters. You know, people get cold sores, just blisters on their lips that we call herpes sores. The only story for this guy that was different is that it's been there for a month and not healing at all. And the people that don't have HIV infection don't do that. And in fact, people with HIV infection with higher CD4 counts don't do that. That's an AIDS-defining illness in and of itself, a herpes infection lasting more than a month. It should go away, and the immune system isn't making it go away. And then I saw this woman, stunning woman in Ethiopia, who had this nasal lesion for 4 months. And I said, come on in, let's talk about it, have a seat. And she said, no. And I said, why won't you sit down? And she said, well, I have hemorrhoids. So I scratched my head and I said, what do you mean you have hemorrhoids? And she said, well, that's what the doctors say. I've come in every month. They've given me hemorrhoid cream. I said, are you better? No. Did any of the doctors ever look at your hemorrhoids? Oh, no, that would be embarrassing. So she's got this thing on her nose for 4 months, and for 6 months, no one has looked at this, which is a huge expanding herpes ulcer on her bottom that would have gotten better with the first visit if somebody had looked instead of said hemorrhoid cream. So on high-dose acyclovir, she got better from both this and this in like a week or two. It really argues that beginning point of always make sure people get a full inspection and evaluation of their skin. In Africa, you know, you have a room with 6 different people in it, and you can't even hear over the noise. And there's supposedly one room over there with a drape where you can be private, but there's no table, no light, no water. You just got to push through and say, I'm sorry, but in this case, we got to make some way to look at this woman because she's been in pain for 6 months. And hopefully we would have done it sooner than that and prevented that. And this is also herpes for more than a month, grinding away and causing a chronic inflammation of the finger called a herpetic whitlow. I don't know how to tell if this is herpes or staph just looking at it, but I knew because I knew the patient. So herpes simplex, if it's more than a month, it's age-defining, or what in these settings is called stage 4 illness, out of 1, 2, 3, 4. The same kind of drugs like acyclovir work, both for treatment and for prevention. If somebody has herpes of the genitals, they're much more likely to spread HIV. So there have been studies showing if we treat the herpes, we can lessen a little bit the spread of HIV. And obviously steroids are one thing you'd want to stay away from. This gentleman had another little mouth sore, and a nurse gave him betamethasone cream and turned into that. So one last blistering rash. Blisters, mucous membranes, this patient is sick. She had been on Triamune, the one with nevirapine in it. What you might say about this rash if you called me is, it bothers me, the rash is getting confluent. The spots are all coming together, and she's got major areas on her chest and her forehead that are spotty. And oh, by the way, she's got some dry, crusty stuff in her mouth, and her eyes hurt her. So this should ring red alarm bells. This is the serious illness you're seeing today. It's called Stevens-Johnson syndrome. It tends to be, oh, and this is how she went over time. It tends to be a reaction, usually a bad reaction to a drug. And you can see she got from bad to worse, where really her skin's falling off. The purple is an old treatment, gentian violet, just to try and lessen infection. And you can see how over time, this is about a whole month's time course, she got better with outpatient treatment. We got lucky. But it's something definitely, if you have somebody with a rash that's starting to blister, that's starting to include the oral mucosa on any continent, not just Africa, the lesions are getting confluent, tender, and the patient's looking sick, you want to worry about these warning signs. So, and we better stop because it's 1 o'clock. But let's just see if there are any questions. We missed a few at the end, but we didn't miss much. Questions? About looking everywhere, about describing lesions. I tried to ask you to, and I do it myself enough times that it'd be easy enough for you to describe a lesion now to your attending resident or whoever you're talking to about what's going on, and get some feedback and then learn. You can look stuff up that way too. Any questions about Africa?
How often in your experience have you seen signs like these that have actually led you to diagnose HIV infection?
Oh, well, the first thing is, you're right, most of these pictures come from an HIV clinic and the people there already have been diagnosed. So what would happen is, my wife has a poverty eradication project, which took us a lot into the villages. So I would see these things, just somebody with shingles, or somebody with PPE. And I would talk to one of the village leaders and I'd say, that young girl over there needs to go to the doctor. I'll just say that much, for that. And it's something we can do something about. So it's common, yeah. And depending on where you go, there are villages on Lake Victoria. Mwanza, I think, is one of them, and there's another one where the fishermen have spread this so much that it's like 30–40% of people have HIV. But really, on every corner, you'll see a dermatologic manifestation, and you just don't know that they either know or don't know they have HIV. So
Is
they're
that a
different
question
areas.
you ask if it's outside of the clinic you were talking about?
Sorry?
Is that something, a conversation you would initiate? Do you know your status? Obviously,
It would
this is
totally
something very
depend.
prominent.
To a complete stranger, it would be a challenge to come up and start that talk. But if I'm there for a reason, like we're visiting an orphanage, and they're saying, gee, we never get medical care for this orphanage, could you offer some? I might listen to everybody's running noses and chests and stuff, and at the end tell the headmaster, I think those two might want to go in for evaluation, and leave it vague and hope the person who's on will figure that out. Because if I say testing and it starts a rumor before anything's happened in the way of social interventions, that probably causes more bad than good. So that's a really good question. I'm going to be going after Africa to Asia and working with some LGBT communities in Myanmar that are still pretty positive, and I think that question will be the same one, if I start to see manifestations. But in that community, probably people know. Like, certainly in the U.S. in 1984, if you got a purple spot, you knew what was going on. Yes, sir?
What percent of the sick people presented with something you could see with dermatology? Or it must have been a lot of them who died who didn't show anything on their skin.
Most of them, I would agree. Either at least a scar from their first shingles attack, or some of the PPE rash. So there was dermatology for involved in almost every patient.
It's incredibly common. I remember the first time I attended Uganda, over half the patients, chief complaint was something dermatology. It's incredibly common, and because that's what people see when it checks out.
And even if they're asymptomatic, they have itchy skin, because everybody has itchy skin, and then they hear somebody in the waiting room say they're looking for itchy skin. So then I said the people have itchy skin, and you hear that. And you think, where'd that come from? But, well, great. Thank you for staying. I know you've got 1 o'clock. I appreciate your participation. For you.